For the patient at initial diagnosis, we need a tissue biopsy to establish that the patient has lung cancer, and sometimes to establish that it's in fact stage 4. And so there should be tissue at diagnosis. When there's optimal stewardship of that tissue, including good communication between who's ever doing the biopsy, the medical oncologist, and the pathologist, limited amounts of that tissue should be used up for defining this to be lung cancer. So in optimal practice, if you have a spiculated lung mass, mediastinal and hilar lymphadenopathy, adrenal and liver mets, and you do a CT-guided biopsy of the liver, you really don't need a 20 IHCs to prove that it's lung cancer, right? And good communication can establish that up front and prevent using up that tissue. And so in optimal practice, in the front line, we would have enough tissue to run PD-L1 and molecular testing on that initial biopsy. And that's it. That's the ideal world. We know, of course, we don't always live in an ideal world. For a variety of reasons, we often don't have enough tissue. And so with upfront testing, if the initial tissue is inadequate for comprehensive molecular testing, liquid biopsy can then come in to supplement this.